Hi, hey, welcome to our virtual lecture. My name is Brian Bizik, and today we're talking about anaphylaxis. This is the AAPP to APP virtual lecture series, and this is our latest, and this is on the guideline updates for anaphylaxis for 2024. In 2020, and then again in 2023, we had updates, and I want to kind of catch you up to date on those. And we're going to do this in about a half an hour. So if you've got 30 minutes, I promise that this will be worth your time. It's going to be very rapid. We're going to go through it quickly, but lots of stuff, I think, to help you. If you've ever heard the word anaphylaxis, this is for you. If you've ever ate food or had a mother in your life, this is for you, because everybody deals with this. We all run into this in one way or another. Patients ask us questions, and keeping up to date on what is going on in this field is really important, and it's hard. This isn't something maybe you get all the time at conferences. So that's what we're going to do. Stick around about 30 minutes, maybe a little bit more, about catching you up on what's new on anaphylaxis. And we have a new product, which is amazing. So we have a nasal epinephrine that just got approved. So I want to at least talk to you about that so you know what's coming. It's the first needle-less way to deliver epinephrine. And so it's out there, and patients are going to ask you about it. So you need to be familiar with the device and how to administer it. And just, is this a good idea? Does this make sense? So we will talk about that towards the end, I promise. All right. So that's me. There's my contact information. Feel free to reach out if you have questions or concerns or have ideas about what we could do next. Allergies and anaphylaxis, because, well, nature kind of hates you, of course. And we love allergies because it keeps us going and it keeps us busy, but they are kind of miserable. What are we going to do? We're going to talk about the definition, because if you can't diagnose this turkey, if you're not comfortable saying that's anaphylaxis, then we don't get anywhere. People sometimes don't know. I mean, not sometimes, a lot of times we don't know. We have a patient in front of us, and is this anaphylaxis? Well, I want to give you the confidence to say, yeah, that's anaphylaxis. And then afterwards, when you document, this is anaphylaxis and this is why. So we're going to do that. Treatment. There's only one treatment. All right. Only one treatment. We're going to talk about it. It's epi first, epi fast. There's 10,000 things people give for anaphylaxis. And guess what? Epinephrine you will give. That's Yoda. Yoda said that in one of the movies. I don't remember which one, but epinephrine you will give. Biphasic. That's the reaction where they have a reaction and they get better and they have it again. Can we predict that? Can we guess when that's going to happen? Do we know the patient in front of us? Well, not really, but kind of. There are risk factors, and I want to show you what the data says about what kinds of patients get biphasic. So at least you can have an idea what the risk is, and tips and thoughts about what you can do. And I'll throw this out. When you give an epinephrine autoinjector, EpiPen or Auvi-Q or whatever, do you need to hold it for 8 seconds? Because I went to a talk last year, and the lecturer said, hold the needle for 8 seconds. And I thought, man, I'm going to hold a toddler that I just stuck in the leg with a needle for 8 seconds. And please don't do that. All right. And I'll show you why. And then Neffy is the new product. So we're going to talk about that. And I'm just going to introduce you to that product. So this is some of my conflicts. None of them really apply to this talk. This is the 2020 update. So if you want to look this up, most of these slides are from this update. However, this is the 2023 practice parameter update, which is really good. And they have, I think, about 45 statements, these consensus statements. I'm going to talk about a few of those, not many, but you can certainly see all those right there. And this article is available free for download for anybody. You don't have to pay for that. So if you want that, there's the reference. All right, let's get into anaphylaxis. Here's my little quote, or it's a little statement. In a few seconds, it was ill. Breathing became distressful and panting, and it could scarcely drag itself along. It lay on its side, seized up with diarrhea, and died. Very sad story, because this was a dog, and this was 1902. And this was Richet's experiments. He had given dogs sea anemone venom, and nothing happened. And then he had given it to them again later, and they died, a few of them. And so he thought that they had protection. And then the second time, they had lost that protection. So phylaxis is protection, and ana is without. So he thought, this is the way to take away protection, and it was named anaphylaxis. He won a Nobel Prize. He got a stamp. I actually have that stamp. I should have got it ready, but I do have that stamp because this is the only anaphylaxis stamp I've ever heard of. So of course, I had to buy it off eBay for $10. That's anaphylaxis history. That's how kind of the first time it came around. What is it? So there's probably no good definition, and there's lots of different ways to define this. And most people say there isn't a good definition, but I want to hammer in a main point about this. Let's look at this. All right. An allergic reaction resulting in widespread symptoms that involves 2 or more organ systems. All right. And so this is if you have a likely exposure or confirmed exposure. However, you don't have to have that known exposure to get to diagnose, all right? So somebody is having a reaction. It's rapid, and it involves 2 or more body systems. If you look at the definitions, this is one of the few consistencies. It's rapid. A lot of times we know there's been an exposure. Either we're sure they had a bee sting, we know, and they know they're allergic, or they ate peanut and they know they're allergic, or we highly suspect there's been an exposure, but sometimes you don't know, right? You just don't know what happened. 2 or more body systems. And you'll see why this makes sense in a minute. This is the newest guideline. So the 2023 guideline updates list it this way. And it says in the top box, anaphylaxis is likely when these criteria, any one of these are met. And so if you look on the left, sudden onset of illness with skin or the mucosa and one other system. Okay, that middle box is 2 or more of these criteria, sudden respiratory symptoms, sudden skin symptoms, or change in either BP or end organ dysfunction, or you've got, loss of consciousness or whatever related to hypotension. And then the third box is just sudden reduced BP after known exposure. So that would be a criteria. You're not going to get that very often outside of the hospital setting. You get that sometimes with contrast media. So 2 or more body systems, that's what you've got to focus on. 2 or more body systems. So if somebody has an exposure or likely exposure, a vaccine, or they ate something, is there 2 or more systems? So skin, respiratory, maybe they're cough, they're tight, reduced blood pressure or associated symptoms. GI is more common with kids. We see that, infants and toddlers. I don't have a big section on infants and toddlers. The 2023 guidelines actually do. So if you're in pediatrics and you need that, you can refer to that. I think if we get some feedback from this talk, I may do just a whole pediatric anaphylaxis talk. And then also reduced blood pressure as a result of exposure to a known trigger. So that's that third box over there. So 2 body systems, all right? When this happens, all right, here's my question. Let's think about this for a second. Histamine, that's the chemical driving this. There's lots of others, right? But histamine is the one we focus on. So histamine is driving this. If somebody has an exposure, let's say a peanut. So the person ate a peanut and they have a known peanut allergy. Okay, so they ate a peanut, however many, 1 peanut. How much histamine are they going to dump? How many mast cells are going to degranulate? I don't know. And you don't know. We don't know how much. And by the way, how much histamine is needed to start this cascade we call anaphylaxis? I don't know. And you don't know. We don't know. We don't know how much, and we don't know how much it's going to take. Is this going to really happen? They ate the peanut and now they've got hives and now they cough. Are they going to still go? Is it going to keep going? I don't know. And you don't know. And in some ways, what I want to encourage you to think about, it doesn't really matter, because if they had an exposure, likely or confirmed, or you think that's a high probability, and in front of you, what you see with your eyes is the progression. And now we have 2 body systems, skin, mucosa, respiratory, GI, cardiac. We've got 2 or more body systems. Then the answer is done. That's the answer. That's anaphylaxis. What you do at that time may be different for different situations, different settings, but it's still anaphylaxis. There's a dumping of histamine, 2 or more body systems involved, and it's progressive. When's it going to stop? I don't know. You don't know. How much does it take? I don't know. And again, it doesn't matter, because at that point, they need treatment. At that point, I'm going to treat. And that's what I want to encourage you to do. So that's the definition that makes the most sense from a day-to-day and working on it. So hopefully think about this and kind of process it now, because if you see it, you need to know. All right, is this anaphylaxis? 12-year-old male with an insect sting, stung once at a park. He had the following. His had hives, his tongue felt thick, didn't look swollen, coughing, wheezing, chest felt tight, runny nose, sneezed once, felt like throwing up. He said, I'm going to throw up, and his hands and feet were swollen. Yeah, okay, that's anaphylaxis, right? Nobody would debate that. All right, another question. 12-year-old male, insect sting, stung once. Sounds like the last kid. Hives, tongue felt thick, did not look swollen, cough, wheeze. Is that anaphylaxis? His tongue felt thick, and he had hives, and he was coughing. Yeah, that's anaphylaxis. Third one, same kid. Hives, tongue felt thick, did not look swollen. That's technically 2 different body systems. Now, if you want to call mucosa and skin the same, then we could say that's one. But this is a concern. His skin is involved, and GI to a degree is getting involved. Maybe it's mucosal. Maybe you want to watch it for a minute, but this is already at risk right here. Very big concern. So it doesn't take it doesn't take every body system to get that. All right. So what brings us on? Mast cells, I think pretty familiar. I'm not going to spend a lot of time on the mechanisms here. That's not part of this talk, but mast cells release the mediators. So they're ready. They're primed and ready to go. If you've been exposed, then they will degranulate and dump chemicals that drive this reaction, chemotactic factors and mediators and pro-inflammatory mediators that start this cascade, okay? Well, first-time exposure may appear mild symptoms. Once you're sensitized, right, so you've seen it once, a very limited exposure, not much, can lead to a very serious reaction. Most occur quickly, all right? Anaphylaxis, food allergy is a very time-sensitive thing. Now, there are a couple of exceptions, so I understand that, and again, kind of a little bit more than the scope of this talk. Alpha-gal, if you're not familiar with that, that can be delayed. There's an issue called scombroid where you're actually eating histamine. It's a different kind of reaction. So those aside, these are rapid. Nobody eats something, again, alpha-gal aside, nobody's going to eat something at noon and have anaphylaxis the next morning at 8. Now, patients will associate the two, but it's not the case, all right? These are very time sensitive, usually in minutes. You can get out a little longer. You can go for an hour or so, but usually it's very quick, all right? The IG is sensitized. The allergen comes in, lots of histamine and other chemicals, leukotrienes, prostaglandins, thromboxanes, and then all of the interleukins that do this, all being dumped. What does that do? What happens? Okay, so I get exposed. What happens? Blood vessels love to dilate. So instead of tightening down, they get big. Permeability, the endothelial lining kind of scoots apart and you can get extravasation of cells and plasma can move where it wants to. Heart rate's going to go up. So just the opposite. So instead of getting open and bigger, the airways get smaller. So it's like asthma, right? It's just going to tighten up. Those beta receptors cause all this constriction to go on. And you can get pain. I've actually had a couple patients with a lot of pain. Mucus secretions, GI, your gut. All of this is designed to kind of protect you, right? Your body's saying, oh, they're breathing in something dangerous. I'll shut down their their lungs. They ate something bad. I'll send it back to them. I'll make them nauseous or vomit. And you get all these symptoms. All of this is because these cells are degranulating quickly and making you miserable. So anaphylaxis, 2 or more body systems. It happens after exposure. Usually we see the exposure. Sometimes you don't. And it's progressive. 2 or more body systems progressing over time. That's anaphylaxis and you need to treat it, okay? Some of the things, urticaria is those, hives, we're pretty familiar. An easy way to remember urticaria versus angioedema. Urticaria is on the skin. Think of it as on top of the skin. It's not, but that's how you see it. Angioedema is in the skin. So this is urticaria. This is on, right? This looks like lesions that are on the skin because we're getting these wheals and these flares. Angioedema is in the skin. Think of it that way. So you can get angioedema. This is angioedematous. See, you can tell this isn't on the skin. I can still see the vermilion border in the lip. This is in the skin. All right. So that's angioedema. Anaphylaxis is severe, potentially fatal reaction. Death can occur within minutes. So that is anaphylaxis, and that's where we're at. These are just some kind of sad examples, but this is still happening. She just had a little bit of peanut sauce. This patient had a toothpaste that was prescription toothpaste that had milk protein in it. Who would have thought about that? Like, you wouldn't think of these things, but it doesn't take much sometimes. Schools putting EpiPens and making them, or epinephrine auto-injectors, making them available. So that's all part of what we're trying to do to get this out there. And epinephrine auto-injectors are found in schools now, which is nice. Airplanes have them now. So they're out there. We just need to be comfortable about the diagnosis and comfortable enough to say, okay, we need to treat this. Anaphylaxis, rapid recognition and treatment. Rapid. It's very quick. This is just the time frame to put in your mind, like what the time frame can be. Food can be delayed a little bit, right? Those are the longer ones, but it can happen in minutes. And then those ones where we don't know, those sometimes are the quickest. And a lot of times those can be induced in the hospital, or they can be contrast media. So can be really fast. It doesn't take long. All right. Recognition. Remember that it's 2 or more body systems is anaphylaxis. Most, not all, but most people have skin symptoms. The younger you are, the more likely to have GI symptoms. The older, the more likely to have hives. But hives up to 80%. Respiratory, a cough, tight cough, that can be part of it. GI, I see that quite a bit. See that in kids. And then cardiovascular, not as common. Sometimes it's a late part of the anaphylaxis. but lots of different ways to notice this. This is another look at where these symptoms are likely to fall out. Last bottom line there, biphasic, I threw that in there. So 5 to 8%, depends on the survey. There's one study published that has it at 21%. I think that seems high to most people, but a wide variety of numbers, but it happens, and it happens not terribly infrequently. And we'll talk about biphasic in just a second. All right, so triggers, what triggers? Medications and stinging insects, most common in adults, food and stinging insects in kids. So just to be thinking about what these triggers can be. When people do pass away, upper and lower is about a little more than 2/3 cardiac, upper and lower airway, and then cardiac dysfunction is less common, but it's part of it. It can be part of it. All right, so kind of shift gears a little bit. I do want to talk about biphasic. I said I would hit on this. Biphasic means the patient has a reaction, they have an exposure, and then they have an anaphylactic reaction. They're treated, or they get better without treatment. They get better completely. And then there's a period of time and they don't have any more exposures and they have a second phase, a biphasic. It's scary. It can happen and it worries us. And it worries us. Like it's always what we talk about with the patients when they're in there. I mean, every time we see it, I work in the allergy field, and one time we had 6 anaphylaxis patients in one day. I'm not joking. But the constantly going through our mind, could this be biphasic, and how do we know, and do we keep them or do we need to send them? So it's the recurrence of anaphylaxis after a period of time without another exposure. So they didn't get stung again. All right. That's biphasic. This is the thing I was referring to, the numbers up there, and that one that was a little over 20% rate. But you can see the different studies and how many people have biphasic. So varies based on ages and where you study it, but it's out there and it's not too uncommon. You'll see it if you treat this. $1 million question, who's going to get it? I mean, if we could figure this out, it would be $1 million. If you had a rapid test for biphasic, and you could test them in the ER or in urgent care or whatever, who's at high risk? So there is some patterns, and this is the best we can do right now. This is the best data we have. What are the risk ratios for people in different categories? So unknown trigger, 1.5, a little more than 1.5 times more likely to be biphasic. So if they don't have any idea what caused this, then we don't really have an idea about the total exposure, and it's riskier. All right, this is the big one. More than 1 dose of epinephrine to stop it. So that first wave, that first hump, did you need more than 1? Almost 5 times more likely. So the way I do it and approach it is that if somebody has more than 1 dose, they go into a different category, and I treat them differently than if they had 1 dose. This is part of the data. I did that before this data, but it's really helpful. Widen pulse pressure, double the risk. Significant symptoms, over 20% of their body. So hives like all over, face, chest. Always look up here. This is where I look when in the clinic, when we're giving people, when we have any question of anaphylaxis, I get this area exposed because you're going to see it right up here on the chest. But this is where it's more than that. Time to first epidose. Those that had biphasic, their average time was 130 minutes. That means they had a reaction and it took forever to get them the epinephrine. So hopefully we get them faster than these 2 numbers, but that's a risk. Kids, drug causes a risk higher. Food, we don't really know, but it seems like that when anaphylaxis is to food, it's less than 1. Hesitant to say that and use that as kind of a guide, but it seems like that. And the thought is that the food proteins causing the anaphylaxis may get broken down by stomach acid, denatured, and now they're no longer able to trigger the same anaphylaxis, the same allergic reaction. Severe anaphylaxis, 2.0. So if they are 2 times the risk factor. So if they had hypotension or more than three systems or more, it's just a higher risk. So that gives you an idea about biphasic. Second $1 million question, how long do you hold patients like with this? Do you I mean, if most of us are going to send them to the ER, which we have a little section on that because the guideline updates that a little bit. But if you're in a facility that's comfortable treating them, you can keep them. Most of us keep them for 1 to 2 hours, especially when they had 1 dose only. We know the trigger. It's lower risk. They're otherwise healthy. But this assumes that they have epinephrine that they can take with them. They have good transportation. I had a patient call me, it was a while ago, a little over a year ago, called me from Costco, checking out, said, I think I'm having a biphasic reaction. So like he was at Costco and he finished checking out and he didn't buy a hot dog. He came back. Second $1 million question, well, second part of this is when you hold them, I mean, can you feel really comfortable with 1 number? And then the number that I would give you, if this is something you're considering, is 6 hours. So We generally don't keep them that long in an allergy office, but if you wanted to know, 6 hours, because about 90% of biphasic will happen by that time. So you can be relatively certain. I don't know any ER urgent care that would set on somebody for 6 hours for this, but you could if you wanted to get to that number. All right. What do? Do we give steroids and antihistamine? Is that why we give them to prevent biphasic? If I give you prednisone right when you have your anaphylaxis, right, and give you your epi and then put 2 prednisone on your tongue? Well, no. Yeah, it doesn't work that way. You don't prevent anything by giving prednisone or by giving antihistamines. Now, you're not going to give it for this. Now, you can give them, and many believe you should, and most of the allergists I work with still do give, and I'm going to show you on a screen just a second what we give them. But what the point here is, you're not giving prednisone to prevent a biphasic. There's no data to support that. So if you give it, that's fine, but just don't say that that's what it's for, and don't document that. Don't say I gave them prednisone, they can't have biphasic, because there's no data to support that. All right. So if you give it, give it. If you give antihistamines, fine, give antihistamines. Albuterol, you do all those things, great, but it's not to prevent biphasic. All right. So we're going to treat now, rapid recognition and treatment, ABC, of course, but I would say this: if it's known anaphylaxis, I would do epi first. I would not do airway, breathing, or circulation. I would do epi first if you have it handy, and then go from there. Risk factors for severe asthma, for severe anaphylaxis: asthma, no epinephrine, or you delay it, it was not given appropriately, or they had other disease. Asthma is the big one for me. And so when we have patients getting allergy shots and things, if their asthma is flaring, we're not going to give them their shot that day usually. So that's a big concern. So epinephrine is the first line treatment. It's the only treatment. You can give it IM or sub-Q. I'm not going to talk about the debate on that one. There's different data. IM is generally thought to give you more medicine quicker and hang around a little bit better, but sub-Q is fine for most of the time. Antihistamines and bronchodilators are not first line treatment. You can do them all you want. Once you give epinephrine and you're ready to give a second dose and you're monitoring the situation, we usually will give them a nebulizer of albuterol if that seems okay. We may give them antihistamines. That's fine. Histamine is the problem. If I give them an antihistamine, that can help. But I'm really treating the later stuff. I'm not treating the anaphylaxis in front of me. Once epi is given, you can monitor and decide if you want to give them anything. Again, you can give what you want, but it's not preventing the biphasic reaction. You're giving it to prevent long-term lingering symptoms that may bother them hours or days later. Okay. We generally do give kids prednisone a little bit. Adults, a lot of times, will get 40 milligrams a day for 2 days. There's no data to say that's a magic number. I'm just telling you kind of what we do. This is not data-based, all right? This is just kind of a little bit consensus. Cetirizine, we'll give maybe 10 milligrams for a couple of days. There's a couple of allergists I work with that will do ranitidine, so they're giving an H1 and H2 from day one. Feel like patients feel better and do better. Step up their inhaler a little bit. Maybe they'll do their albuterol every 4 hours for a day and then go back to as needed. That's always fine. Make sure you refill their epi and just go from there. I'll say that we are backing off of this, and then it is changing. Very different. 15 years ago, everybody got this, and I mean everyone got it that I knew. Every allergy office I knew did this. So it's changing, and you may work somewhere where this is changing, and that's great. I think the data is not there for, I don't think. The data isn't there for giving these things. It makes us feel better, right? It's like a blood pressure pill. I'm going to give it to my patient. They don't feel better, but I feel better knowing they take it. So maybe that's why. And so we're changing, but I just want to tell you what a lot of people give. All right, this is, I do think, super important. What does epi do? Like, why am I giving epi? And the main thing I want you to take away from this is everything. I could just put one word: everything. Every single bad thing, every bad thing that happens with anaphylaxis is reversed with epi. How quickly it works and how long it works, that's the other questions that we talked about, but it does reverse everything. So it causes blood vessels to constrict. It causes airways to open. It changes the way the heart is beating. The force and the contractility change and go back to normal, and does help prevent kind of this wave of mast cell degranulation. It kind of helps with that and helps stabilize those. So there is a mast cell stabilization component. So it reverses just about everything. It can take a few minutes. It can take longer. It can take many minutes, but often you can kind of see it. And I could tell you stories of maybe 8 or 10 patients where I saw their hives kind of form, and then I saw them unform in the opposite way. It was pretty cool to see. Now, if you give epi, all right, let's talk about, if you give epi, you're going to give a patient epinephrine. So you're sitting there, you think this is anaphylaxis. You see a patient, 2 or more body systems, maybe they have hives and they're coughing. Okay, skin and respiratory, 2 or more systems, check, exposure likely or whatever. They have a history, they have an arm, they have a bracelet on, whatever. This is likely anaphylaxis, and I'm going to treat them. What if you give them epi and they didn't need it? What bad stuff happens? We need a list of all the bad stuff that happens, except for there is no list because nothing bad happens. There is no bad. There is no contraindication. You should never, ever, ever, if they have 9 pacemakers everywhere on their body, give them the epinephrine. I don't care. Move a pacemaker aside and give it. It doesn't matter. If the patient in front of you has an evolving, progressing allergic reaction, you don't know how much histamine they're going to dump, and you don't know how much histamine they need to have an anaphylaxis reaction that kills them. You don't know that, and I don't know that, and nobody does. But what you see is a progressive allergic reaction, and you have a medicine that stops every aspect of that. Use it, okay? I'm going to take that tan box and make it bigger so you can read it. But this is a very good, it's a little bit older, 2019, but a really good report. Dr. Lieberman put, this is great, and I've heard him talk about this. If you take that box and make it bigger, based on current data, there's no absolute contraindication to epinephrine, all right? Failure to give it is the problem. Clinicians concerned about adverse effects may be reluctant to give it. Education is important. So I don't know, pregnant, give it. A kid, give it, all right? It's an adult and all you have is Epi Junior, give it, give 2. I've poked myself twice with Epi, once on purpose in front of a talk, one on accident in front of a talk. Nothing happened. Well, I talked faster, which was good because I struggle with talking faster. This is from the 2023 practice parameter updates. Just real quick, serious adverse reactions to IM Epi are very rare and should not pose a barrier, all right? We recommend that you get familiar with them and understand that, yeah, they're going to feel jittery and their blood pressure may go up a little bit and there may be some things going on. They may feel a little bit of tightness in their chest because things are opening up, but generally speaking, there's not much. This is just a list of some of the epinephrine auto-injectors out there, just if you want to link to them. I'm not going to talk about it a lot. If you're not familiar with this one, I'm not promoting any brand. I don't work for any company, all right? Unfortunately, because these would be great companies to work for. But this is a smaller one that's designed to fit in your pocket. Kids seem to like this a lot, especially because they can carry it. When you pull it out, it talks to you. There's an audio and a visual component to the instructions, thus the name AVIQ, audio visual cue, right? So it's a good one. I love it. And if this is something that is covered by their insurance, it's a great option. Look at the auto-injector lacerations, though. Do you want to hold it for 10 seconds? So these are kids that had EpiPens given to them, and somebody tried to hold them for, whatever, 8 seconds, and the kid jerked away, and we got this. This is still better than anything. I mean, even if this happened 10 times, you would still give the Epi. But do you need to hold it? And so this is a great study you can look at. I'm going to make one little part bigger. I'm going to take that little part, okay, and make it bigger. But the conclusion right here is no linear relationship exists between Epi injected and absorbed. The data suggests that holding the device for 1 second is as effective as 10. I don't think you need to count to 1 and stop, but the best bet is to administer the epinephrine, hold it down as long as it takes to hear it click, to register and see that it's gone in, and then remove it. And that's usually about 2 seconds. And that's absolutely fine. It's going to work just fine. And if you're teaching patients, counseling, you can say, do it this way. And if they think they didn't go in and you want to give another one, I would like to not have to give another one because you need that second one for, as a backup. But if you have multiple epinephrine auto-injectors at home, you could give one. And if it didn't go in, give another one. Better to give. Better to give. Do not hold back on this if there's a suggestion. This is one of the consensus statements in the new update. So there's a whole bunch of them. This is number 26. And this is one of the big changes. So this is one of the things in the new guidelines that I thought was very interesting. We suggest, I'll read this to you, we can read together. We suggest clinicians counsel patients that immediate activation of EMS may not be required. So this is very different. And this kind of came out of COVID a little bit, but it also makes really good sense. And I'm so happy about this because the statement from the consensus group is this: if a patient gives themselves Epi, or somebody gives them Epi and they have a great response and there's another epinephrine auto-injector ready to go and people are comfortable, you do not have to go to the ER. We know that patients and parents didn't give Epi because they didn't want to go to the ER. And so this can help make some suggestions. The next 2 slides are for reference. I'm not going to read them, but if you want to look at them and pause the video and read them, you can. This is general guidance about when you should activate. Okay, so green, kind of green, yellow, red, if you will, about when you should do and not. So you can read that if that's something that's interests you, but it is something to talk with your patients about and saying, look, if you have a really good response, a lot of times it's happened before, and you're comfortable, you may choose to give this and not activate EMS, not call 911, all right? This is another reference slide I won't read to you, but how to decide what to do, and you can use this in your clinic if you want to keep a patient or send them, or if it's for the parent or caregiver, you can give this information, okay? Can I do this at home? Can I manage this at home or not? This is a great reference, and so I just wanted you to have that and read that if you need it, okay? All right, we're almost done. I just got a couple minutes left, and so, hey, Neffy was approved. So this is exciting because we have a new option. This is a nasal delivery product. I'm really excited about it. The company did a great job bringing this to market, and it's exciting to have something that's different. So this is the product. It's the only one right now. I'm not trying to promote this product over anything else because there isn't any other options right now, but we have an option for a nasal spray. This is the only kinetics study I'm going to show you. I'm just going to show you one slide, but what this is showing you is that when you give nasal, so it's a nasal spray, you saw the device, you hold it in your hands and you deliver the nasal spray. When you give that nasal spray, these are the levels of epinephrine, comparing it to IM and sub-Q type of auto-injector dosing of this, okay? And you can see the Neffy is it's a 2 milligram dose. So it's what, 7 times more, but it's given very differently, right? It's going through the nasal mucosa, but very similar reaction, very similar pharmacokinetics. The levels in the blood, very similar. It's kind of in between an epinephrine auto-injector and an IM injection. It's kind of halfway in between in a lot of the data. Not so much here, but there's other data. But it looked very similar. The effects on cardiac contractility, heart rate, and blood pressure, those two were very similar. So it's exciting that there's a new way to give epinephrine to patients. And we're excited in the field just because it's nice to have this option for our patients. I've already talked to patients and they love the idea. So this is great. I don't have any idea about the cost. I don't know if it's going to require coupons. That will be coming, I'm sure, from the company. They are getting ready to bring this out and to roll this out, and it'll just be fun. It'll be fun to be a part of this. This just tells you a little bit about it. Very effective and safe, no needle, less hesitation. Patients like this. And I put at the bottom, I thought it was fun, that what about if they have a runny nose, if they have congestion? Well, at least some of the data shows that the epinephrine absorption and uptake was a little better if they had a runny nose. So far from being a contraindication if they have a runny nose, it seemed to be fine. No data on nasal pulposis, so if patients have that or a severe deviated septum, I think it might be fine, but I don't think there's any data. So no recommendations on that. So for those patients, you may want to stick with an auto-injector, but that'll be fun. It'll be fun to see if we get data on that. So exciting thing. This is how to use it. It's administered like a nasal spray. You don't really need to suck in or pull, try to pull that medicine back. It's same hand. So if you use fluticasone nasal spray, opposite hand is much better. Right hand to left nostril, left to right. So you want to use opposite hand for nasal corticosteroid sprays or anything if you're putting in Astelin or anything in your nose, it's opposite hand is much better, because you don't want to hit the middle. You don't want to hit the plexus and it just causes problems. This is not that way. So it's the same hand. So you just put it in the nostril. That's the same hand. You depress it. It snaps up. And then the recommendation obviously on here would be to activate 911. But as you know, that may not be necessary depending on the patient situation. If you need another dose, it's in the same nostril. You just give the same dose to the same nostril. It's going to come in a 2-pack. It's exciting. So that's it. That's all I have on there. Thank you for watching. Hope this helps diagnose, be comfortable what anaphylaxis is. 2 or more body systems. It's progressive. They're going to get epinephrine when you're done. If you want to give them prednisone and you want to give them antihistamines, that's great. It won't prevent biphasic, but it may help some of the longer lingering symptoms, and it'll help you feel better, right? Even if it doesn't help them. If you don't feel like giving them prednisone, I think that's fine. And the data would support that more than giving it, I think, at this time. And just encourage patients, epi first, epi fast, encourage parents to give it. Don't hesitate to give it. No bad outcomes if you give it and they didn't need it. There's never a bad outcome. If you give it and it was given prematurely, good. You got comfortable and you did it and you know you're brave and you're fine. And I just, the praise I give patients when they actually use it is I just try to just throw it on them because I want them to be very confident, comfortable. With nasal epinephrine, we may not need quite as much goading because I think they'll be more willing to use it. So that's also very exciting. If you have questions, here is my information. And again, you can reach out to me anytime and be happy to help. And thanks for watching APP to APP.